Right, well, I'm Rosamond Vallings, and I'm a doctor, and I live and work in Howick, which is a suburb of Auckland, and I've been involved with chronic fatigue syndrome for probably about 40 years. My interest actually started before that, when I was at medical school, and we learnt about this illness because there was a very big epidemic in a nearby hospital which affected doctors and nurses, a big flu epidemic, and many got left with what we now know as chronic fatigue syndrome. It was called royal free disease then, and we learned a lot about it at medical school and had inpatients with it. And then I finally came to New Zealand and saw an advertisement to work with a rheumatologist doing some research in this illness, and I got involved in a part-time way, and my interest just grew from there. Good morning, everybody. Well, here I am to talk to you today about ME, chronic fatigue syndrome, and what I'm going to do is give a little bit of background to what the illness actually is, talk about making a diagnosis, management strategies, and we'll cover some of the important aspects of the up-to-date research. So certainly we know for sure that in the majority of people, this illness is usually triggered by some sort of viral illness. There has been shown to be a genetic vulnerability, meaning that you possibly inherit the genes that make you more likely to get this illness, though not proven absolutely. And generally, the symptoms are due to changes in the immune system, which becomes very overactive, leading to inflammation in the brain, changes in the underlying body chemistry, imbalances in your gut. And this all leads to lots of symptoms, and many of the symptoms generally do overlap or mimic the initial illness. In New Zealand, we probably have somewhere between 20 and 40,000 people with the illness, prevalence of up to about 1%. The ongoing illness is often very mild, particularly in children. They're able to carry on at work and school, or it can be very, very severe, leaving people totally bedridden and needing ongoing care. It does affect all age groups, and I've seen children as young as 4 through to the very elderly, but it's very, very hard to make a diagnosis in the extremes, like young children who can't tell you an awful lot, and of course elderly people who often have many other underlying problems with their health anyway. Certainly more common in females, about a 60%, 70% more common in females, and there may well be some hormonal links. A number of factors make one more prone to getting the illness. We've already mentioned the possible genetic predisposition. There may well be underlying issues already going on, such as an athlete who's pushing the body hard, or there may have been exposure to toxins, an accident, surgery, possibly pregnancy. Immunisations upset the immune system, and in many people there will have been a history of sleep deficit in the lead up or at the time of onset, but most likely the viral illness is going to be the trigger. Which viral illness? Well, any really. We certainly see, particularly in young people, a very high incidence of glandular fever, which we call infectious mononucleosis, which triggers it off. But that's not the only trigger. It can be any trigger. And of course, with COVID coming into the picture now, we're hearing about long COVID, which may or may not turn out to be the same sort of thing. There will often be that combination of factors in the lead up, such as problems with sleep or pushing the sport hard, and often the herpes group of infections, which cover a wide range of bugs, they may be infected. This includes things like glandular fever and shingles, So, you know, we have all sorts of viruses out there, many of which we possibly have never had identified, which can lead to this, even the common cold. A typical scenario we sometimes see with glandular fever, for example, in a teenager, there will be what we call immune activation, and there's huge amount of surge of this immune activation when you get very first sick. The majority of people who get, say, glandular fever will have recovered in 1 month, 90% of them. About 9% will have ongoing symptoms, which can sometimes be quite mild, and we call that post-viral syndrome or the post-viral phase, and that can last up to about 6 months. But here we are needing to be alert to the possibility that this could be leading on to chronic fatigue syndrome. These are the sort of people that get ME, not just athletes, but I just put this one up as an example because we have to be very alert to the fact that here we are, a very sporty nation, and many people who get a viral illness go back to their sport far too soon, and this may lead much more readily to an ongoing illness, such as we're talking about today. So what are the main symptoms? Well, certainly because it's generally called chronic fatigue syndrome, obviously fatigue is the principal issue. Very, very tired often, and people who have not suffered this kind of tiredness ever before. And it's a fatigue that's not resolved by having rest. So you may well think, oh, well, I feel very tired, I'll go and lay down with a book after lunch and maybe fall asleep for half an hour, but they don't feel any better after that kind of rest. And we also have very much prominent in the diagnosis what we call post-exertional malaise. And this means that after exercise, or not even exercise, just sometimes very minor effort, there's an extreme tiredness which worsens with that activity. There are an awful lot of what we call cognitive problems too, and cognitive problems are the sorts of problems you get with brain activity. It's almost like the post-exertional malaise, but it's particularly relating to using your brain. So it's particularly hard for people trying to get back to work or study. There's a very high incidence of what we call orthostatic intolerance, and this means feeling very, very lightheaded if one is standing for any length of time or gets up suddenly, a feeling of almost dizziness or faintness, and that's accompanied often by a very rapid or erratic heartbeat and feeling quite ill. A lot of people with this will have ongoing flu-like symptoms such as sore throats and glands coming up, feeling feverish and so on. And a lot of pain often in unexplained places. There may be, for example, pain in the muscles or gastrointestinal pain, headaches, what we call fibromyalgia, which is pain particularly relating to muscles and movement. And there will often be a lot of gastrointestinal disturbances. So people become intolerant of certain foods or feel very easily upset in the gut. And almost always there will be some form of sleep disturbance. Maybe not being able to get to sleep or being very restless. Certainly the common complaint is, I never feel refreshed by my sleep. So there's been an awful lot of research going on for at least the last 70 odd years. This goes back to a number of earlier described epidemics in the past in places like London and Iceland and Los Angeles, epidemics which have led to ongoing illnesses such as we're talking about today. A lot of studies have been done over the years, and in the early years, of course, they didn't have the sophisticated and elaborate technology which we have today. I mean, unfortunately, a lot of that elaborate technology that we do have today, it costs an enormous amount of money. So research is somewhat hampered by that. Certainly a lot of the work going on looking at genes, so-called epigenetics, which is the way genes work, all these things require a lot of expertise and expensive equipment. The illness generally affects many symptoms of the body, and as a result, treatment can be a little bit more specific at relieving some of those symptoms. And it may be in the end that we will be recategorizing this illness because there are so many different kind of brands of it, really. Those who have problems particularly with the brain, those whose problems are particularly orientated towards exercise or the gut, and so on. And we may be eventually saying, well, chronic fatigue syndrome is just a big umbrella term for a number of different illnesses. A huge amount of research going on now, and I won't have time today to go through all this in detail because, well, it would probably take me a week to go through it. But as you can see, a lot of areas of the body and management and treatment strategies are being researched, and that's hugely encouraging. And certainly, particularly in the States, they have huge amounts of money being put aside for these research projects because it's being realized, of course, that this is an extremely serious and life-altering illness, really. Many people can't return to work, or students can't continue with their studies and so on. A lot of the research is looking particularly, and I'm just picking this one out of that list of one of many, looking at what we call metabolomics, which is the underlying body chemistry and the way different metabolites are measured in the body. And there was quite a breakthrough a few years ago by a man called Navio in the States, and he measured 612 of these metabolites in 63 different pathways. And this is your underlying kind of body chemistry, really, and found abnormalities in 20 of the pathways. This was a major breakthrough, and it was published in a very prestigious journal called Nature. And it was likened to the state that animals are in when they are in hibernation, the medical term for that being dower. So that was a really important breakthrough, finding these abnormalities. Also, there's a substance called H2S, hydrogen sulfide, and it may be that higher levels of this particular chemical in the system create this hibernation state. And a further study done a little later on showed that the vitamin B12 may be protecting the mitochondria from this hydrogen sulfide damage. Mitochondria being the powerhouses in the every cell of the body, really. Now, again, this isn't absolute and proven totally, but there are ideas that may well lead to better ways that we understand and manage this illness. Then, of course, a lot of the researchers looked at what we call a biomarker, and a biomarker, of course, is a way of diagnosing an illness accurately. For example, in diabetes, we know that high sugar levels create the symptoms of this illness, and in thyroid disorders, high or low thyroid levels create the particular diseases associated with that. So people have been looking endlessly for a long time now for what we call a biomarker for this illness, which actually proves whether you've got the illness or you haven't. Now, if we could put this whole list here that I've given you into one single test, that would be absolutely incredibly wonderful. But unfortunately, that's not possible. These are abnormalities that have been found, but they are not absolute for this illness. They can occur in other illnesses as well. But we're getting closer. And I think, you know, it won't be long with the very sophisticated equipment that we now have before there will be a standalone test, or maybe a combination of just one or two of these tests, which actually show that you definitely have this illness. Now, of course, a biomarker must be specific to the particular illness. It's no good, you know, we say, okay, there are certain things going on here, but maybe it could be occurring in another illness as well, such as, well, let's say multiple sclerosis. We've got to be really, really sure. And that's why research into a biomarker takes so long, because there are many, many diseases that have to be checked out as well to make sure that the abnormality that's found as a possible biomarker isn't occurring in lots of other illnesses as well. So it's a very prolonged, expensive and difficult procedure. But there are a couple of biomarkers I'll mention that are quite exciting, really. And one of them, again, I wouldn't expect you to really understand this because I barely understand it myself, but one of them is in Australia on the Gold Coast. Don Staines and Sonia Marshall-Grudesnik, a couple of very prominent researchers, have found that there is an abnormality in the way that calcium moves in and out of cells. Now, calcium moves out of in and out of every cell in the body, and there's a little receptor thing which controls the way this happens, the so-called TRPM3. And again, you know, it's a kind of, this is all minuscule, and they need extremely expensive equipment to find these things, and it's not something that's simple. But they have found abnormalities there, and there is certainly enough evidence now to say this is a very strong possibility as a biomarker. And then Warren Tate, who is of course down in Dunedin, had a publication a few months ago on SWATH-MS analysis. Now, again, I'm not a biochemist, I'm not an intense scientist, so a lot of it I find quite hard going to understand. But this particular study was looked upon as being a really, really important one towards our understanding of the illness and the potential for a biomarker. And of course, Warren Tate's research is ongoing with a very expert team, and he does have some support, particularly from the local ME society here. And, you know, we watch with anticipation, as this is extremely important, and little old New Zealand is well ahead here. So he describes the whole thing as a molecular jigsaw, which is slowly fitting together. And of course, there are still some gaps, but the gaps are beginning to fill in. So that's really exciting and encouraging for us all. And moving on now to the area that I feel more comfortable with, and that's making a diagnosis and managing the illness, what we need to do. So first of all, when a patient comes to the doctor with this possible diagnosis, the doctor should be able to take a history and, if necessary, examine the patient and do routine blood tests and other investigations that may seem important in light of the symptoms described. Important too to have some sort of psychological evaluation, because, as I'll explain shortly, a lot of underlying psychological illnesses can have very similar symptoms. But we're looking really at a process of elimination, and there are very definite what we call diagnostic criteria for making the diagnosis, and these have been described in Canada and internationally, Institute of Medicine in the States, and it's important that the diagnosis is made according to a reliable set of criteria. And this has nothing to do with it being unusual or anything for ME. This is true for every illness. We're taught this method of making a diagnosis in medical school. And if the patient doesn't fit the criteria for this diagnosis, we have to consider other possible diseases that might be causing the illness. And symptoms are often overlapping with other conditions. So there are various other things we would look at. Certainly people who are depressed or have psychological illnesses often have a lot of very similar symptoms: tiredness, brain fog, headaches, sleep disorder, and so on. And similarly with neurological diseases, things like MS, motor neuron disease, these often start with a very similar kind of set of symptoms. And if a person is very obese, they will feel extremely tired much of the time and have symptoms like pain because of joints and muscles having to carry extra weight, unable to sleep properly, and so on. And of course, we must never forget undiagnosed cancers. And I don't want to scare you, but it's really important to be looking at other possibilities. And some of the hormonal imbalances we see, such as thyroid disorders, can certainly have very similar set of symptoms. And there are a number of what we call overlapping conditions as well. You probably heard of POTS. This is the feeling very lightheaded when you're standing up, and you can have POTS without chronic fatigue syndrome, or part of it, the way the system controls your balance, dizziness, that sort of thing. Fibromyalgia, which is not the same exactly as chronic fatigue syndrome, but many, many people will have that as well. Ehlers-Danlos syndrome is loose jointedness, something you're born with, but tends to make you more prone to this illness. Autoimmune, mast cell disease, so on. That whole list certainly, and I mean, it's only the beginning list, really. There's a very much longer list. These are the common things that do overlap, and some of them very much more readily treatable. And so if the illness, let's say a sleep disorder, is treated efficiently, then the person's chronic fatigue syndrome may become a very minor issue. May still have it, but it may be much easier to manage. So how do we move on with what we would call a management approach in light of our common knowledge to chronic fatigue syndrome itself? Well, first of all, certainly making a correct diagnosis is absolutely vital. Doesn't matter what illness you have, if the diagnosis is not correct, then the treatment strategies are not going to be possibly working well at all. We also need in every illness to look at stress management, because both mental and physical distress, and by physical distress I mean pushing the body too hard, these will aggravate every illness in the book. So teaching a person good stress management skills, or looking at the stresses in their life and trying to eliminate them or help them with them, is really important. And also everyone with not just this illness, but any illness that sort of knocks you down a bit, needs to try and get some time outside regularly, daily. This way we metabolize vitamin D properly. The way we manage the melatonin responses in our body, which relates to sleep. These things all relate to having good daylight exposure, and ideally unfiltered sun, not just through a window. Exercise is important in that people need to be as active as they can comfortably manage, but it's really important not to be pushing the exercise hard. I describe it as cautious pacing. In other words, you do a little, see how you are afterwards. It's often not while you're doing the exercise, but it's how you feel afterwards, the so-called post-exertional malaise. And in Britain, the guidelines, the NICE guidelines, have been changed to eliminate the push for too much exercise in this illness, which can be very, very damaging. So cautious exercise is the way to go. You might find you can only walk 20 paces. That's fine. If you do it, reasonably regularly, and don't be tempted to suddenly go from 20 to 40 to 60, but maybe 20 to 22. So in other words, a really, really gentle approach. Diet needs to be balanced and nutritious as best you can, avoiding things you know for sure seem to upset you. And most people with this illness do have very low blood pressure, and so we recommend extra salt, which helps maintain that and helps overcome some of the symptoms of the so-called POTS or orthostatic intolerance. We also add in a drug called fludrocortisone if the blood pressure is very, very low, and that helps to maintain better blood flow to the brain. And that's an important aspect of management. Supplements, of course, people will spend their life savings sometimes, and we need to be cautious about what one takes. It's not just saving money, but also some supplements will be totally inappropriate, and some supplements may be damaging or just lowering your bank balance. So looking regularly at things that may be appropriate. And if you have a definite deficit in your diet, maybe you're a vegan, you might need extra iron, for example, then that's appropriate. But for the actual illness, the only supplements that regularly I would be recommending would be magnesium, which can help with sleep and sometimes gut problems. B12 seems to be particularly useful, and B12 injections have been shown to be helpful for many people, though not absolutely everyone, but certainly some people do very well on them, and it seems the higher B12 levels achieved have a beneficial effect on energy and brain function. Coenzyme Q10 being looked at by Professor Tate and his team in Dunedin, as well as other people, and that's been shown to be a useful supplement taken in the mornings for some people. And vitamin D important for people who are totally inside and unable to get direct sunlight. We look at hormonal management, and particularly in light of the fact that, as I said at the beginning, more women than men seem to get this illness, so there may well be hormonal links. And we're not just talking about the female hormone replacement, we're looking at other hormones such as thyroid and other hormones that may be out of sync. You're also looking at treatment for POTS, as well as the salt and fludrocortisone, learning how to overcome this particular set of symptoms by not standing for any length of time, for example, in the hot sun, wearing support hose, elastic stockings that can help keep the blood in the higher part of the body, which means getting into the brain more readily, and so on. There are a lot of treatments for these sorts of things, and often a good physio is a good option there. But needing to deal with sleep is really high on the agenda, because anyone with any illness who's not sleeping well is going to get problems regarding the way their recovery from a good night's sleep occurs. So if you're not sleeping properly, you're not going to feel refreshed in the morning, and all your symptoms will be worse. And there's certainly a lot of aggravation of sleep in an illness such as this. So we tend to use a group of drugs called the tricyclics. In larger doses, they're used to treat depression, but for sleep, we are talking a mini dose, which improves the quality of your sleep. Melatonin can help, particularly if you don't have much daylight exposure. And promethazine, which is an antihistamine, is useful for sleep for people who have a lot of trouble with allergies, mast cell disorders, and so on. Need to look at pain control. And again, the tricyclic group of drugs, very handy here. Pregabalin is another drug that we sort of use now more readily for the fibromyalgia type pain, and low-dose naltrexone, LDN, which I will talk about a little bit more in a minute. There are a number of other drugs being trialed for this illness, but the one thing I would stress is that always we start with low doses. That's really important, because this illness creates an extreme sensitivity, not just to drugs, but other things as well. Certainly people develop more sensitivity to food, more allergies, that kind of thing. That's just a sleep cycle as an example of what's going on. And we have these various phases of what we call REM sleep, which is the dream sleep, and the phases of deeper sleep here. And you need both sets of sleep really to get a balanced sleep pattern, which leads to the correct restoration of brain function, production of hormones during deep level 4 sleep, and so on. And if you don't get that kind of sleep, then you wake up feeling unrefreshed and often quite a mess. So people with chronic fatigue syndrome often don't get that proper sleep. And this is where the use of tricyclics particularly does help to restore a more normal sleep pattern, which in turn leads to a better chance of recovery. So the sleep studies have been ongoing and are really important. And if you can get a good restorative sleep, you're more likely to recover. And having a good sleep routine is really, really important. Same sort of time to bed, not laying in bed all day, sleeping. I mean, certainly a lot of people need to rest in bed a lot in the daytime, but trying not to sleep too much in the daytime, making sure maybe that sleep naps are very short. Someone needs to wake you up, or you might need to put an app on your phone to wake you up, or what have you. A man called Martin Partanen in Finland has made some really positive breakthroughs in understanding the sleep cycle. And he particularly has focused on what we call the orexin system. The orexin system is not new, it's been known about for a long time, but it's kind of become more topical in relation to this illness now. And if your orexin levels are low, this triggers off sleep. And so what helps make your orexin levels low, having high glucose leads to increased feeling of sleepiness due to the fact that orexin then becomes low. So we're talking about a snack at bedtime of some sort, anything really, because your body has the ability almost magically to change whatever you eat or drink into what it requires. So if you have, let's say, a drink of milk at bedtime, or a cheese and biscuit, that will transfer into what your body needs, a sort of higher level of glucose, which then gives you a feeling of being more sleepy because your orexin levels go down. There is a drug that can be used. It's in its early days in research for this illness, but there may well be options there that could be helpful. Well, there are a lot of drug trials going on, not just for sleep, but for all sorts of different reasons. And some of them, like, for example, the sleeping sickness drug called Suramin, is no longer available regularly, but Ron Davis in the United States has found that the drug that we use for sleeping sickness, mainly in Africa, of course, this is caused by the tsetse fly, this drug could have benefit in chronic fatigue syndrome. So he's been trying to get it available for research. These are again, I won't go through all these different things because it would take a long time, but I'll just mention two in particular. Pyridostigmine is a drug that's used for a neurological disorder or disease called myasthenia gravis, and this particular illness has a lot of very similar symptoms to ME. However, it's a more degenerative type of thing, and it's treated with this drug called pyridostigmine. This is nothing new. Both myasthenia gravis and pyridostigmine have been around for a long time, but certainly some people, and again, we're talking a smallish percentage really, of people with chronic fatigue syndrome, ME, do benefit from pyridostigmine. And the other one I'll mention, again, because it's very topical at the moment, is low-dose naltrexone. And naltrexone is a drug which is used to help people come off things like heroin, morphine addiction. And it's used for those conditions in high doses. It's pretty safe. Even in high doses, but what they've found is that certainly people with chronic fatigue syndrome have shown some benefit from very low doses of this drug, and we are not talking everyone. And I've used it quite a lot for patients over the last probably 5 years. It's taken in very, very tiny doses. And I mean, we're talking starting 1 milligram. And if you're treating a drug addiction issue, we're talking 50 milligram or more. So, you know, we're talking a mini dose. It may not suit everybody. There may be side effects for some people. And I found generally, if I did a bit of a breakdown, about 1 in 3 people would have no benefit whatsoever, even when we push the doses up here to about 9 milligram. About 1/3 of people would say, well, they didn't have very pleasant experience with it. They had mild side effects, some had major side effects. So we're left with 1/3 who actually do quite well on it. And some of those 1/3 do very, very well. And we don't fully know who's going to benefit. Important before we use it to check other medication being used, because there may be conflicts there, or even with supplements possibly, because, you know, you don't always remember to tell the doctor what you might be taking. People nowadays bring stuff in from overseas, and, you know, I'm sometimes quite horrified when I hear of what people are taking. We need to be sure that the person understands what the drug is going to be doing, how it works, how long they might need to be on it, and starting with this very tiny dose and increasing slowly. Probably for most people don't need to go as far as 9 milligram. We're talking maybe about 5-6 milligram a day maximum. Need to give written information about what to expect, and there will be some people who do get insomnia with it. So I usually say, take it in the mornings. If, however, you happen to feel really thick-headed all day, which a few people do, then you would be better to change to evening taking, because you probably wouldn't get insomnia. And it can take about 6 weeks to show benefit. It is quite expensive and has to be ordered through specially from a particular company who make it up in Auckland. And it's really important, of course, with any drug that we use, we make sure that the doctor that's looking after the patient normally is well informed about what to expect. So low dose naltrexone, yes, a possibility, but probably only for about 1 in 3 people. The mechanism has been kind of described a little bit more reliably by the people that I mentioned earlier on, Don Staines and his team in Queensland, and they have found that these M3 receptors, which control the movement of calcium in and out of the cells, has been abnormal in a high percentage of people with the illness, and the LDM possibly corrects this abnormality. This is all very early research, very high-powered research, but it gives us a feeling of some confidence that what we're doing is not just snake oil, that we're actually doing something that has got some good possible research background benefit. So what other issues are there ongoing? Well, certainly hormonal issues are always in the background with regard to female patients. People want to know whether it's safe to get pregnant or not. And we do know that the majority of patients with this illness who get pregnant actually do very well in pregnancy. And this may well be due to the fact that they get better brain blood flow in pregnancy. There's a kind of excitement, expectation, so mental well-being is good. And the hormones that you produce in pregnancy do have an effect of relieving a lot of aches and pains, and also sometimes improving brain blood flow. So pregnancy isn't a no-no, but of course one has to weigh up the pros and cons then of coping with a baby, and that can be quite a big issue to overcome in one's mind, I suppose, though most women do generally with this illness cope extremely well, and they often get a lot of help from family members and friends and so on. Then there's contraception, and again, because of the benefits of estrogen, which is one of the main pregnancy hormones, going on to some form of oral contraception that contains estrogen can be helpful. So often young women may not need contraception, but they may do very well on the contraceptive pill. And older women, maybe 45 plus, generally do quite well on hormone replacement as well. You have to weigh up the pros and cons, side effects, other risks and so on, but these are options which for a number of women can be really, really useful. Then we were going to talk about immunisations, and of course that's come up a lot now with the COVID-19 issue. Work going on between various immunologists and Professor Tate in particular, and the immunisation board here regarding changing the protocol for people with chronic fatigue syndrome, in that maybe mini doses will be a safer option to try it out anyway, because some people have certainly reported bad reactions to the COVID vaccine. However, there have also been a number of people who've done well after the COVID vaccine. So again, it's as always a bit of a mystery. Other immunisations, again, can be weighed up according to need. Some people do manage to tolerate them all right. Others prefer to put them on hold and choose a time when they're feeling their best. Regarding the COVID vaccine, certainly having an antihistamine dose for a day or two before and a day or two afterwards can alleviate any risk of allergic reaction. And sometimes we use the drug prednisone to help as well. So these things are issues to be weighed up in light of the current things that are going on. The other issue that's important is regular surveillance, of course, and maintenance of your day-to-day health and well-being is really important. And watching for new symptoms. Just because you get a new symptom doesn't mean to say that you are going to be blaming it all on your chronic fatigue syndrome. It may be something completely different, and it is perfectly possible to get, unfortunately, other illnesses as well. So any new symptoms should be viewed with caution and reported to your doctor for possible surveillance or investigation. And the other reason to have regular surveillance, of course, is that there may well be new treatments coming on the horizon which haven't been regularly mentioned before, and your doctor may well become aware of something new which you haven't become aware of, which can then be suggested as a trial. I think it's important to say that over the years, I have found about 1/3 of my patients with chronic fatigue syndrome who themselves have thought they've had the illness, or sometimes I've thought they've had the illness, about 1/3 we end up with a totally different diagnosis. And often these will be things like psychological problems, or a new illness that's been lurking in the background that suddenly shows itself. Or it may be, of course, too, there's aging. And as we get older, we all become more prone to different illnesses, degenerative conditions, and they have shown that in chronic fatigue syndrome, there's a slightly increased risk of aging earlier. And I mean, that might be a bit depressing, but it's the reality. The so-called telomeres, which are little sort of spikes attached to your chromosomes, they age a little bit more rapidly in some people with chronic fatigue syndrome. They sort of wear out a bit sooner. It's not necessarily a major issue, but it's something to be aware of. So we move on to what other important messages are there. I think it's fair to say that all the symptoms with this illness are going to be aggravated by stress, over-exercise, overactivity, and so on. And watching for things that you found yourself aggravate. It may be certain foods, for example, or certain activities that you undertake that just don't agree with the way your body happens to be. So you need to learn to identify these issues and pace very, very carefully. Regular daylight exposure is important, as I said right at the beginning, and of course keeping yourself stress-free as best you can, learning some deep breathing techniques, meditation, mindfulness, using music, it's really powerful, and certainly for a lot of people, seeing a good physio can be good, because the physio may well be able to help you with an exercise plan that's appropriate, and also teach you some good breathing techniques and other ways of dealing with stress. So don't be afraid to take on board other health professionals. And that means also keeping a check on your general well-being, things like good dental care, attention to wax building up in your ears, you know, simple sort of stuff, which when it's corrected can make a big difference to your overall well-being. So we're looking at also having good support networks in place, and certainly you can find out about support groups in your area and join ASWATH-MS, which provides a very regular good magazine, and the CCIS support group, which is very important too if you're in their area. They provide a lot of useful information and meetings and so on. So all these things are worthwhile getting your fingers on, because they can be useful for the way you handle your health, both at home and in the wider community. I think it's fair to say all patients can experience a better quality of life with compassionate care and a multidisciplinary approach, such as we've been outlining. And I think you need to feel in control of your health rather than being controlled by the illness itself. If you're in control, you will do better. And there's some resources which I think can be easily printed out, and good websites that you can get onto. If you go number 1, 2, 3, 4 down, the Australian module here is actually for doctors. and they can acquire medical education points for doing that one. And your doctor may well want to learn more about the illness, so that's an option. And even for patients, it's a very useful learning tool. I think this is an illness which should be managed by your doctor, and there's a very simple plan really, such as we've outlined today, which most doctors will have learnt about. That sort of plan in medical school. It's the way we manage every illness really: diagnosis, treatment plan, management plan, follow-up. It's the kind of regular way we deal with illness, and I think there's more and more education now for doctors in medical school, and I think you'll find that thankfully things are going to be a lot more easy as time goes by. I wrote a book here, as probably many of you know, which is mainly for patients, but many doctors have actually bought it and said, well, it's a nice, easy kind of textbook. So I'll keep on updating that as best I can. And hopefully, as a result of all that's going on in the background, this illness will gradually become a thing of the past, maybe something that we know enough about that we can be sure that people are going to recover in the end. Many people do recover. Sadly, not all do at the moment, but that's going to change, I'm sure.